You know, those moments, maybe days or even weeks, where your mood and energy aren't just fluctuating a little bit. They feel like they're kind of catapulting between extremes.
Hmm.
These aren't your typical ups and downs. They're, well, really intense shifts that make just getting through the day incredibly challenging, sometimes almost impossible.
That's
Yeah,
right. We're talking about shifts in mood, energy, activity levels that are uh, pretty unusual and significantly impact a person's ability to function. Day-to-day stuff.
exactly. And that profound impact, that's really what we're exploring in this deep dive. Today, we're focusing on bipolar spectrum disorders.
Yeah, and our guide for this is a chapter on bipolar spectrum disorders from Barcarolis Essentials of Psychiatric Mental Health Nursing, along with some slides. It
Hmm.
gives us a really solid clinical look at things,
Right.
how these conditions present, what might be behind them, and, the different ways they're understood and managed.
So our goal here is to really unpack what these disorders are, get a handle on how they actually manifest, touch on the, well, complex picture of what contributes to them,
Yeah, it's definitely
and
complex.
explore the various treatment approaches.
Mhm.
We want to give you a clear, insightful picture without getting totally lost in the weeds. Let's dive in.
Okay. So at its core, a bipolar spectrum disorder, it's considered a brain disorder. It's characterized by those unusual shifts we mentioned.
Mood, energy, activity.
Exactly. And they lead to significant difficulties in a person's life.
And this source is really clear. These are serious conditions. They're described as chronic, recurrent, potentially even life-threatening.
Yeah, and capable of causing significant health issues, long-term disability. That chronic piece is really vital to grasp. And what's also striking is just how varied the symptoms can be. Some people might live with really quite significant symptoms for years before they even get a diagnosis or look for help.
And the name itself, bipolar spectrum disorders, that tells you it's not just one single thing, right? It's a whole group of related conditions.
Precisely. The source outlines different types within the spectrum. Probably the most well-known is bipolar I disorder.
Okay.
This requires at least one episode of full-blown mania. And importantly, these manic episodes, they're often accompanied by or maybe followed by at least one episode of major depression.
Right.
The key here is that the manic symptoms, they have to be severe enough to really mess with social or work functioning, significant impairment. And psychosis can even be present in either phase.
Mania or depression.
Yeah, either one. And that often necessitates hospitalization.
Okay, so bipolar 1 is really defined by that experience of mania. What about bipolar 2 then? How's that different?
So bipolar II disorder is distinct. It's characterized by at least one episode of hypomania, which is like a less severe form of mania.
Okay, hypo meaning less.
Exactly, less severe. And that alternates with one or more periods of major depression. The absolute key difference, the thing to remember, is someone with bipolar 2S never experiences a full manic episode.
Never full mania.
Never. And interestingly, the source points out that people with bipolar 2 often have more frequent and sometimes maybe even more severe depressive episodes than folks with bipolar 1.
Huh, that's interesting. So hypomania and depression for bipolar 2 versus mania and depression for bipolar 1. What about the third type they mentioned, cyclothymic disorder?
Right, cyclothymic disorder. This involves longer-lasting but milder mood swings. It's characterized by episodes of hypomania alternating with what are called persistent depressive symptoms.
So not quite full major depression.
Exactly, symptoms that don't meet the full criteria for a major depressive episode. And that this pattern, it needs to be present for at least 2 years in adults, 1 year in kids. The mood extremes are less severe than in bipolar 1 or 2, but the variation is chronic. It's ongoing.
So less extreme ups and downs, but they're happening pretty consistently over a long time.
Yeah, exactly. And the source points out symptoms typically start in adolescence or early adulthood. And there's a significant risk, anywhere from like 15 to 50%, that someone with cyclothymia could go on to develop bipolar R2 later on.
Wow. Okay, so it really underscores that spectrum idea, doesn't it?
It really does.
That makes sense. Now let's really dig into what these mood states feel like, what they look like. The source talks about this as a continuum of mood.
Yes, it's helpful to picture it like a line, maybe. Severe depression on one end, moving through milder depression. Then you've got a stable mood in the middle. Then you start going up into hypermania, then full mania. And in really rare cases, there's something called delirious mania, which is the absolute most severe end.
Okay, let's focus on the manic episode first, since that seems central to bipolar R. What defines it?
A manic episode is a distinct period where someone has an abnormally and persistently elevated, expansive, or maybe irritable mood. And that's coupled with abnormally and persistently increased activity or energy. This has to last at least 1 week, or really any length of time. If it's so severe, it requires hospitalization for safety.
Right. And what are the kinds of signs we might see during this time?
Well, you typically see 3 or more of these symptoms, or 4 if the mood is just irritable, not elevated. Things like an inflated sense of self-esteem or grandiosity.
Feeling invincible.
Sort of, yeah. Or believing they have special powers.
Mhm.
Also, a decreased need for sleep. They might feel totally rested after only, say, 3 hours.
Wow.
They're often much more talkative than usual, sometimes with this feeling of pressure, like they have to keep talking. Their thoughts might race, jumping rapidly from one idea to the next. That's called flight of ideas.
Okay.
They're easily distractible, pulled towards any little irrelevant sight or sound.
It sounds like their mind is just running at hyperspeed.
It really can feel that way. There's also usually an increase in goal-directed activity, maybe socially, at work, school, or sexually.
Yeah.
Lots of energy poured into things. And this is where it gets particularly risky. Excessive involvement in activities that have a high potential for painful consequences.
Like what?
Things like, unrestrained shopping sprees, reckless sexual behavior, making really foolish business investments without thinking it through.
Oof. That combination of poor judgment and just boundless energy sounds incredibly dangerous. How does that look behaviorally?
Behaviorally, yeah, you might see hyperactivity, constantly on the go, starting tons of projects but finishing very few. Highly distractible, as we said. Their judgment is impaired, which leads to impulsivity.
Mhm.
The source also notes they can sometimes be manipulative, find fault with others, maybe be quite adept at exploiting vulnerabilities,
Yeah.
pushing boundaries significantly.
Right.
Physically, they can go for days with very little sleep or food. That puts them at serious risk for physical exhaustion, even death in extreme cases, so it needs careful monitoring. Their appearance or grooming might also become unusual or inappropriate.
It paints a very intense picture. And how does this affect their communication, their thinking?
Their thought processes and communication are often markedly altered. Delusions can be present, sometimes grandiose, like believing they're famous or have special powers, or sometimes paranoid.
Okay.
Hallucinations can occur too, particularly auditory ones, hearing things. These are actually more common in mania than in depression.
Interesting.
And their speech patterns become very characteristic. There's pressured speech that's rapid, really difficult to interrupt. Flight of ideas, that rapid, loosely connected shifting between topics we mentioned. Sometimes you hear circumstantial speech, where they include excessive, unnecessary details before getting to the point.
Right. Rambling a bit.
Yeah. And in severe cases, clang associations, where they start speaking in rhymes or puns, but the words don't really connect logically.
So their thoughts and words are just spilling out fast, often disorganized.
Yeah.
Now, you mentioned hypomania as like a less severe version of this.
Exactly. A hypomanic episode has those similar symptoms, elevated or irritable mood, increased energy and activity, those other signs, but they're milder.
Milder how?
Well, the duration is shorter. It lasts at least 4 consecutive days. There has to be a noticeable change in functioning, something uncharacteristic for them, but it's less severe. Occupational and social functioning aren't usually impaired to the same degree as in full mania.
Okay.
And a critical distinction. Psychotic symptoms like delusions or hallucinations are not present during hypomania.
Got it. Less severe, shorter duration, no psychosis, less impact on day-to-day functioning. And then the other end of the spectrum is the major depressive episode.
Right. A major depressive episode requires 5 or more specific symptoms to be present during a 2-week period. And crucially, at least one of those symptoms must be either a depressed mood or a marked loss of interest or pleasure in things they used to enjoy. Anhedonia.
What are some of the other symptoms on that list?
Well, beyond the depressed mood, which can actually present as irritability sometimes, especially in younger people, and that loss of interest or pleasure, the source lists significant weight changes, up or down,
Right.
or changes in appetite, sleep disturbances, either insomnia or sleeping way too much, hypersomnia, psychomotor agitation or retardation, so either feeling really restless and keyed up, or feeling physically slowed down, fatigue, loss of energy, feelings of worthlessness or excessive inappropriate guilt,
Yeah.
difficulty thinking, concentrating, or making decisions that, like, cognitive piece. And very importantly, recurrent thoughts of death or suicide, sometimes with a specific plan, sometimes not.
So these are symptoms many might associate with depression, generally, but in the context of bipolar disorder, they're alternating with those hypomanic or manic states.
Exactly. That cycling is key.
What happens when someone experiences both extremes kind of at the same time?
Ah, yeah, that's what's called a mixed episode. This is when someone meets the criteria for both a manic or hypomanic episode and a major depressive episode nearly every single day for at least a week.
Wow, that sounds incredibly difficult.
It can be a very distressing state. Imagine having all that restless energy, but also feeling profound despair or irritability. It's tough.
I can only imagine. And that most severe rare form you mentioned earlier,
That's delirious mania. Very rare, thankfully, but life-threatening. It's characterized by a really rapid onset of delirium, confusion, disorientation combined with mania, and often psychosis. It can involve something called hyperactive catatonia.
okay,
The source notes it's typically managed with high doses of benzodiazepines or sometimes ECT. It's an emergency situation.
it really shows the sheer range and potential severity. The source also talks about adding diagnostic specifiers. What are those about?
Specifiers are basically extra labels added to the main diagnosis. They provide more detail about the specific features of the current episode or maybe the overall pattern of the disorder over time. They help paint a more complete clinical picture for treatment planning.
Like what kind of details? Give me an example.
Sure, they can specify things like whether there's significant anxious distress present or if there are mixed features happening, even if it's not a full mixed episode. They might note if there's a significant suicide risk or if marked irritability is a major feature. A really important one is rapid cycling. That means experiencing 4 or more distinct mood episodes, manic, hypomanic, mixed, or depressive, within a single 12-month period. The source highlights that rapid cycling is often associated with, well, less overall functioning, a tougher course.
4 episodes in a year. Wow.
Yeah. Other specifiers could include things like a seasonal pattern to the episodes or whether psychotic features like delusions or hallucinations are present during mood episodes.
That adds another layer of complexity, really, to understanding an individual's specific experience. Okay, let's shift gears a bit now and talk about how common these disorders are and what other conditions often kind of go along with them. Comorbidity.
Sure. Looking at prevalence, the lifetime rate in the U.S. is estimated around 4.4%. The average age when symptoms first appear is about 18.
So often starting quite young.
Yeah, often in late adolescence or early adulthood. But about a third of people report their onset was even earlier, between 13 and 18. And it can also show up later in life, even up to age 60 or 70 sometimes.
Any differences between men and women?
For bipolar I disorder, it's roughly equal, about a 1-to-1 ratio. But bipolar 2 is actually more common in females. The ratio is about 1 male to 2 females.
Interesting.
And the way it first presents often differs too. Men are statistically more likely to have their first episode be mania, while women more often present initially with a depressive episode.
That's a really interesting distinction. And you mentioned these disorders often appear alongside other conditions. How common is that, really?
Yeah, very common. Comorbidity rates are high. The most frequent co-occurring mental health conditions are anxiety disorders. Also, things like impulse control disorders and ADHD are pretty common too.
Right. And I know substance use is often linked as well, isn't it?
Yes, absolutely. Substance use disorders are highly comorbid. And tragically, having a substance use disorder alongside bipolar disorder significantly increases the risk of things like rapid cycling, having mixed episodes, and particularly the risk of suicide. The source presents a really sobering statistic here. Anywhere from 25 to 50% of individuals with bipolar spectrum disorder attempt suicide at some point.
Yeah.
And tragically, 15 to 20% complete suicide.
Wow. That statistic is incredibly stark. It really underscores that life-threatening nature you mentioned right at the beginning.
It does. It's something that always needs to be assessed and managed carefully.
What about physical health conditions? Do they co-occur too?
Yes. High rates of medical conditions often go along with bipolar disorder. This includes cardiovascular problems, metabolic disorders like type 2 diabetes, endocrine issues. It's also important because certain medical conditions like hyperthyroidism or even using substances like amphetamines can actually mimic manic symptoms.
Oh, right. That could make diagnosis tricky.
It really can. A thorough medical workup is essential.
I can imagine that would make figuring out what's truly going on much harder. Okay, so we've seen what these disorders look like, how common they are. Let's turn to the big question. Why do they happen? The source makes it pretty clear it's not a simple, single answer.
Absolutely not. The development of bipolar spectrum disorders involves a really complex interplay of multiple factors. You've got environmental factors, genetic factors, neurobiological factors. It's a mix.
Let's start with genetics.
Yeah.
How strong is that link?
It's considered strongly inherited. There's a definite genetic predisposition. First-degree relatives like parents, siblings, children, they have a 7 to 10 times greater risk than someone in the general population.
7 to 10 times higher risk. That's significant.
It is. And if both parents have a bipolar spectrum disorder, the risk for their child can be as high as 50%. And identical twins. If one twin has it, the other twin has up to an 80% chance of developing it too. That's a really powerful genetic signal.
Wow, yeah, that 80% figure for identical twins is huge.
It really points to a strong biological underpinning. The source also mentions there seem to be shared genetic roots with other conditions like schizophrenia spectrum disorders, depression, and even ADHD.
So some overlapping vulnerability, perhaps. Beyond the genes themselves, what about differences in the brain? Neurobiological factors.
Yeah, experts point to underlying problems with specific brain circuits and also how neurotransmitters function. It's complex, definitely not just a simple chemical imbalance, but
Right.
the general idea is that there might be higher levels of certain neurotransmitters like dopamine and norepinephrine during mania,
Wow.
and maybe low serotonin contributing to depression and possibly also playing a role in aggression or impulse control issues in mania.
Okay.
Functional brain studies show differences too in activity and even structure in areas of the brain critical for regulating mood, making decisions, controlling impulses, places like the prefrontal cortex, the limbic system, the amygdala.
So it's not just the chemicals, but how the brain's wiring in different regions are working together, or maybe not working together properly.
Exactly. And neuroendocrine factors are also implicated. Abnormalities in the HPA axis, that's your body's main stress response system, are often seen. Studies show higher levels of stress hormones like cortisol in people with bipolar disorder. Hormones might also play a role, with symptoms sometimes being more severe in women, particularly linked to times like the premenstrual period, pregnancy, or menopause. And there's growing interest in the role of inflammation, which might interact with the stress response system too.
It really is a multi-layered biological puzzle.
Yeah.
What about environmental and psychological factors? How do they fit in?
Oh, they're crucial too. They often act as triggers, especially for initial episodes or relapses, interacting with that underlying biological vulnerability.
Okay.
One concept the source discusses is something called behavioral approach system, or BAS dysregulation. Think of the BAS as a kind of brain system linked to motivation, reward, goal seeking, your GO system.
Right.
In bipolar disorder, this system might be dysregulated, swinging wildly, so excessive activation leads to that hyper-responsiveness, high energy, maybe even euphoria you see in mania, while deactivation, or shutting down, results in the lack of motivation and energy seen in depression.
So it's like the internal drive system is either stuck on overdrive or completely stalled out.
Kind of like that, yeah. A bit like the accelerator being jammed on or completely disconnected. Another really important idea is the social rhythms theory.
Okay, what's that?
This suggests that disruptions to a person's daily routine and their circadian rhythm, their internal body clock, particularly sleep deprivation, can provoke or worsen episodes.
The sleep connection again.
Exactly. Our daily social demands and tasks, things like when we eat, when we work, when we interact with people, they act like social zeitgebers, cues that help set our internal biological clock. When these predictable rhythms get disrupted, it can lead to instability and trigger mood swings.
That makes so much sense, especially given how often sleep is severely disrupted during manic or depressive episodes.
It really connects the dots between daily life patterns and the underlying biology. And finally, significant stress and trauma are recognized risk factors and triggers. Things like family conflict or major changes in sleep patterns are strongly associated with initial episodes. Stressful life events can certainly trigger episodes later on too, and childhood trauma is identified as a significant risk factor for developing the disorder in the first place.
Wow. So it's really clear it's not just one thing causing this. It's this complex interaction between a person's genetic vulnerability, their brain function, and then their life experiences, their environment, stress.
Precisely. It's a biopsychosocial picture.
Okay. So given all this complexity, how is care typically approached? The source outlines the nursing process, and it seems like there's a really big emphasis on safety, especially early on.
Safety is absolutely paramount, yes, especially during acute episodes, mania, or severe depression. The approach to care is really guided by the individual's current phase. Are they in acute mania? Are they depressed? Or are they in a more stable maintenance phase?
What does assessment look like, particularly when safety is a major concern?
Assessment starts with physiological safety. Basic needs. Do they need to be in the hospital to stay safe? Have we ruled out other medical causes or substance use that could be mimicking symptoms? Are they dehydrated? Is their heart okay? Are they in physical danger from just not sleeping or eating?
Right, basic survival stuff first.
Exactly. Then there's behavioral safety. Are they unable to control their actions? Is their poor judgment putting them or others at risk, financially, sexually, physically? Is there a risk of self-harm or harm to others? Assessing that immediate risk is critical.
So immediate physical and behavioral risk assessment. What happens next?
Well, once things are a bit more stable, the assessment expands. You want to understand the patient and family's knowledge of the disorder. What do they understand? What education do they need about medications, about support systems, community resources? The source also highlights assessing cognitive function. This is important because difficulties with things like memory, attention, executive function planning, organizing these can be persistent challenges even when the mood is stable, and they really impact long-term outcomes, like going back to work or school.
That's a crucial point, that cognitive stuff can linger even after the mood episode itself seems better. So what are the typical goals for treatment then?
Outcomes are often framed in phases. So in phase 1, the acute mania phase, the absolute overriding goal is to prevent injury and ensure safety. Period.
Makes sense.
This includes measurable goals like, achieving adequate hydration within 24 hours, getting enough sleep, even just 4-6 hours initially, is a huge win in acute mania, maintaining stable vital signs, ensuring they maintain self-control to prevent harm to self or others.
Okay, immediate stabilization and safety. What about looking longer term?
Right. Phases 2, which is continuation, and phase 3, maintenance, they focus more on fully resolving symptoms, preventing relapse, which is really key because it's a recurrent illness, and limiting the severity or duration of any future episodes.
Okay.
So goals here shift towards things like the patient and their family attending psychoeducation programs, participating in therapy or support groups, developing better communication and problem-solving skills, and critically, sticking to the treatment plan, including medications.
So the initial focus is intense safety and stabilization, and then it broadens out to long-term stability, coping skills, relapse prevention. What does actually implementing care look like during that acute manic phase? It sounds challenging.
It can be very challenging, yes. Planning and implementation during acute mania are intensely focused on safety and managing those outward symptoms we talked about. This includes interventions to help decrease that excessive physical activity, finding safe outlets for energy, ensuring they eat and drink enough because they often neglect it, helping them get adequate sleep, addressing any basic self-care needs they might be neglecting, and careful medication management is key.
And hospitalization is often needed then.
Frequently, yes. Especially in acute mania, hospitalization is often necessary to provide that safe, structured environment where these interventions can happen effectively and consistently.
Okay. And how do healthcare providers communicate effectively with someone who's in acute mania, given the racing thoughts, maybe irritability, distractibility?
That's a really key nursing skill. And the source gives some valuable guidelines. The approach needs to be firm but calm, not authoritarian but steady. Think simple, direct statements. The example they gave was something like, "John, come with me, eat this sandwich." Short, clear, concrete. Keep explanations really short and concise. Avoid long, complex sentences.
Simple and clear. Makes sense when someone's thoughts are racing.
Exactly. It's also vital to remain neutral. Avoid getting drawn into power struggles or making value judgments about their behavior. Consistency is absolutely crucial. Everyone on the care team needs to be on the same page with expectations and limits.
Right, a united front.
Yes. You set limits in simple, concrete terms. You explain the consequence if they can't control their behavior, often framing that consequence like maybe needing some quiet time in a seclusion room as something that will help them regain control, not as a punishment. It's also important to use active listening for any legitimate complaints they might have, even amidst all the other stuff. And a key technique is firmly redirecting their energy into more appropriate channels. Distraction can be a really useful tool for de-escalation.
The source included a little story, a vignette with a nurse and a patient named Gloria that kind of illustrates some of this, didn't it?
It did, yeah. You can see the nurse using redirection, gently shifting Gloria's focus when she's upset about losing her job, asking about her pets, which is a calmer, more neutral topic for her.
Right.
The nurse also uses reflection, saying something like, "I'm guessing you feel upset about the job," which acknowledges Gloria's underlying feeling without getting caught up in the intensity of her current manic state. And you see the use of those simple guiding statements like, let's walk together, which aligns with that calm, firm approach. It really shows how these techniques can work in practice to manage the interaction and redirect that manic energy.
That's a really helpful example. You mentioned seclusion and restraint earlier, briefly. How do those fit into the picture? They sound quite serious.
They are serious measures, and they're used only when absolutely necessary. When a patient is dangerously out of control and all other less restrictive interventions like redirection, verbal de-escalation, offering medication have failed. The seclusion is basically involuntary solitary confinement. The idea is it reduces overwhelming stimulation, protects the patient and staff from harm, and prevents property destruction. It's warranted only when there's a substantial immediate risk of harm and the patient genuinely cannot control their actions.
And restraint.
Restraint is any physical method, device, or equipment that immobilizes someone or reduces their ability to move freely. Again, used only in emergencies to prevent imminent harm.
Right.
The source really stresses that both seclusion and restraint must be an absolute last resort. They have to be used strictly according to hospital policy and legal guidelines with intensive monitoring for safety.
So strictly for safety in really extreme circumstances when nothing else works.
Yeah.
Okay. Now let's talk about medication. That's often a cornerstone of treatment for bipolar disorder, right?
Yes, medication is usually essential. Mood stabilization is the primary goal, and the specific drugs used can vary depending on whether the person is in a manic, depressive, or mixed episode, or if they're in the maintenance phase trying to prevent future episodes.
And lithium is often the first one people hear about, isn't it?
Yes, lithium is kind of the classic mood stabilizer. It's still considered a first-line treatment for acute mania, and it's very effective at preventing both future manic and depressive episodes. It also has the unique benefit of being shown to reduce suicidal ideation.
That's huge.
It is, but it can take a few weeks, maybe 3 to 6 weeks, for its full stabilizing effect to kick in.
What's really important for someone taking lithium or their family to know?
Well, the source highlights its effectiveness, but it also really stresses the need for careful monitoring. Lithium has what's called a narrow therapeutic window, meaning the amount in the blood needs to be just right, not too low or it won't work effectively, but not too high because that can become dangerous, even toxic.
Okay.
So while we don't need to get into the exact numbers here, it's absolutely crucial for patients and families to understand that regular blood tests are necessary to check the lithium level, especially when starting or changing the dose, and then regularly long-term to make sure it stays in that safe and effective range.
Right. And what kind of things might signal that the level's getting too high, becoming a problem?
Good question. Even at therapeutic levels, someone might experience expected side effects, like maybe a fine hand tremor, some increased thirst and urination, maybe mild weight gain, sometimes hair loss. Those are generally manageable. But it's vital to recognize signs of toxicity. Early signs could include things like the tremor getting worse, more noticeable, persistent nausea, vomiting, or diarrhea, increased thirst and urination beyond the usual, maybe slurred speech or muscle weakness.
Okay, those sound like clear warnings.
They are, and if it progresses, more advanced signs include a really coarse tremor, persistent GI upset, mental confusion, muscle hyperirritability, maybe changes on an EKG, poor coordination, ataxia. Severe toxicity can lead to seizures, coma, kidney failure, and even death.
Wow. So what should someone do if they suspect toxicity?
If toxicity is suspected, even the early signs, the immediate action is to hold the next dose of lithium and contact their healthcare provider immediately. Don't wait.
Got it. Urgent.
Yes. This is why recognizing those early signs is so incredibly important. The source also emphasizes key patient teaching points. Maintaining adequate fluid intake, like 8 to 12 glasses of water a day, is essential, especially if sweating a lot, like in summer, or if they have diarrhea or vomiting.
Why is fluid intake so important?
Because dehydration can actually cause lithium levels to rise dangerously. Sodium intake also needs to be kept consistent. Big changes in salt intake can affect lithium levels too.
Okay.
Avoiding certain other medications, like NSAIDs, that's ibuprofen, naproxen, or certain diuretics, without talking to the provider first is also crucial, as they can increase lithium levels. And importantly, never stop taking lithium abruptly, as that can trigger a relapse.
That makes it really clear why careful management and ongoing education are so vital with lithium. What about other types of medications used as mood stabilizers?
Right. Antiepileptic drugs, AEDs, or anticonvulsants are also frequently used, sometimes alone, sometimes in combination with lithium or other drugs.
Why use those?
They can be particularly useful for individuals who maybe don't respond well to lithium, or for those with specific patterns like rapid cycling, mixed states, or if they have comorbid conditions like substance use disorders or anxiety.
Okay.
They work differently than lithium, but also help stabilize mood.
Okay. Any key examples or things to watch out for with these AEDs?
Yeah, common examples include valproic acid, which is also called Depakote, carbamazepine, Tegretol, and lamotrigine, Lamictal. Like lithium, they often require monitoring to sometimes blood tests to check the drug levels or to monitor potential effects on the liver or blood counts.
Hmm.
For example, the source notes that carbamazepine might require weekly blood monitoring for the first 8 weeks because of a rare but serious risk of blood problems. There are also other potential side effects to be aware of. Lamotrigine has a warning about a rare but serious skin rash called Stevens-Johnson syndrome, so the dose has to be increased very slowly.
Okay, so careful titrate.
Exactly, and valproic acid carries significant risks during pregnancy, potential birth defects, so it's generally contraindicated in women of childbearing age unless they're on reliable birth control and have discussed the risks thoroughly. These are all really important conversations to have with the healthcare provider.
Absolutely. So, like lithium, they're effective tools, but definitely require careful monitoring, awareness of potential risks, and open communication.
That sums it up well. And then there are the second generation antipsychotics, sometimes called atypical antipsychotics.
Used for psychosis.
Well, yes, they treat psychosis, but they're also very commonly used now as mood stabilizers, particularly as first-line treatment for acute mania because they can work quite quickly. Examples include drugs like olanzapine, quetiapine, aripiprazole, risperidone,
Yeah.
several others. They're also used for treating bipolar depression. Some are specifically approved for that, like lurasidone, and many are used for maintenance therapy to prevent relapse, sometimes alone or added to lithium or an AED. Some are even available as long-acting injections, which can really help with adherence for some people.
So, quite versatile then. And finally, ECT was mentioned earlier as a treatment option.
Yes, electroconvulsive therapy, ECT. It often gets a bad rap from movies, but it's actually a very safe and highly effective treatment. It's used for severe or treatment-resistant bipolar disorder episodes that haven't responded well to medications.
When else might it be used?
It's also used when a very rapid response is needed for safety reasons, like in cases of extreme suicidality, severe agitation, or catatonia. And it can be a particularly important option for severe episodes during pregnancy, where medication choices might be more limited or carry risks for the fetus.
Okay, so a whole range of medications, often used in combination, tailored to the individual's specific needs and the phase of their illness, all requiring careful monitoring and management. But medication isn't the whole story, is it? You mentioned psychosocial interventions are critical too.
Absolutely essential. Yeah, the source really stresses this. These interventions aren't an alternative to medication. They work alongside pharmacotherapy. And they significantly improve outcomes, they reduce the risk of relapse, enhance day-to-day functioning, and help people stick with their overall treatment plan.
What are some key examples of these psychosocial interventions? What do they involve?
Well, psychoeducation is foundational. It's really about teaching the patient and their family about the disorder itself.
Like what?
Like, what are the symptoms? What are the potential causes? What are the treatment options? Why is medication adherence so important? How can you recognize early warning signs of a relapse? What lifestyle strategies help maintain stability? Things like regular sleep, managing stress.
Hmm.
The source lists goals like understanding the illness, learning to manage it as a chronic cyclical condition, learning to track moods, and developing self-help strategies. It's really about empowering individuals and their families with knowledge and tools.
Giving them the tools to understand and actively manage the condition. Makes sense. What else?
Cognitive behavioral therapy, CBT, is another widely used approach. CBT helps individuals learn how to identify and challenge negative or flawed thought patterns and behaviors that contribute to mood instability or problems.
How does it do it?
It's pretty practical. It focuses on developing skills for symptom management, identifying and avoiding triggers for episodes, problem-solving skills for dealing with life stressors, and strategies for stabilizing daily routines like sleep schedules and meal times. It helps people change how they think and what they do.
Okay, focusing on tangible skills for daily life management.
Precisely. Then there's interpersonal and social rhythm therapy, IPSRT. This therapy is based directly on that idea we discussed earlier that disruptions in interpersonal relationships and daily routines can trigger mood episodes.
The social rhythms theory connection.
Exactly. So, IPSRT helps individuals learn to regulate their social interactions and their daily schedules, wake time, meal times, activity times to help stabilize their biological clock and consequently prevent mood swings. It directly targets that routine aspect.
Connecting social life and daily routine directly to mood management. Interesting.
Yeah, it's quite effective for many people. Family-focused education therapy, FFT, is another important one. This involves working with the whole family system.
Why involve the family?
Because bipolar disorder doesn't just affect the individual, it affects the whole family. FFT uses psychoeducation and therapy techniques to improve communication within the family, enhance problem-solving skills, and help the family learn how to support the individual effectively without getting overly stressed themselves. Research shows it can actually lower hospitalization rates.
Having supportive, understanding relationships sounds incredibly important then. And what about support groups?
Yes, support groups, like those run by organizations such as the Depression and Bipolar Support Alliance, DBSA, or the National Alliance on Mental Illness, NAMI, are invaluable. They provide a sense of community, which reduces isolation, something people often feel. And they offer the huge benefit of shared experiences and practical knowledge from peers, people who really get it because they've been there, both for the individual with the disorder and for their family members.
Peer support is powerful, and technology is playing a role now, too.
Yes, the source mentions informatics, basically the use of technology. Things like smartphone apps can help individuals track their mood and symptoms day to day, set medication reminders, maybe even facilitate communication with their treatment team or family support network. It's a growing area for supporting ongoing self-management.
So it sounds like a really comprehensive approach is needed.
Yeah.
Medication is usually the foundation,
Right.
but it's combined with this whole suite of therapies and support systems to help individuals manage what is, for most, a chronic condition.
Exactly. It's not just about treating an acute episode, it's about achieving long-term stability, preventing relapse, and supporting the person in living a full, meaningful life despite the illness.
And how is the effectiveness of all these different interventions measured? How do you know if it's working?
Evaluation is ongoing, it's not just a one-time thing. In the short term, especially coming out of an acute phase, you're looking for those safety markers we talked about. Vital signs stabilizing, hydration improving, achieving adequate sleep, even if it's just 4 or 5 hours to start an acute mania, that's progress. Demonstrating better self-control.
Okay.
Longer-term goals focus more on outcomes like sustained adherence to the treatment plan, meds and therapy, regaining function in the community, work, school, relationships, achieving stable relationships, maintaining overall mood stability over time, and developing better coping skills for managing stress.
It's clearly a journey then, with both immediate safety goals and those longer-term goals for stability and function.
It really is. And it requires consistent effort and collaboration between the individual, their support system, family, friends, and their treatment team.
Well, we have really taken a deep dive into bipolar spectrum disorders today, drawing heavily from this nursing text and slides. We've navigated the definition and the different types of bipolar 1 to cyclothymia. We explored the often intense clinical manifestations from severe mania down to major depression and those tricky mixed states.
Covered a lot of ground on symptoms.
We touched on the complex interplay of factors contributing to their development, the genetics, the neurobiology, the environmental triggers, psychological aspects.
That biopsychosocial view.
Exactly. And we outlined the multifaceted approach to treatment, emphasizing that it involved essential medications alongside these really vital psychosocial therapies and supports. And throughout, we kept coming back to the critical importance of safety, especially in those acute phases.
Yeah, it's a complex picture, isn't it? Really illustrates how biological vulnerability interacts so strongly with life experiences, stress, and even just daily rhythms.
Absolutely.
Yeah.
And you know, that actually brings us to a final thought for you, our listener, to maybe consider, building on everything we've discussed today. Given the chronic, often lifelong nature of bipolar spectrum disorders and the significant impact of things we talked about, like daily routine, stress, social factors, alongside the biology, how might our broader communities, our healthcare systems, maybe even our workplaces and social structures need to evolve to provide the kind of truly integrated long-term support necessary for individuals to achieve and maintain stability and well-being?
That's a big question. Definitely something to think about.